Good afternoon. Thank you, Raju, for this wonderful opportunity and a wonderful meeting. My talk today is unusually located perimeniscal cysts. As we know that perimeniscal cysts are common occurrence and they are not very uncommon, but at times they may be situated at uncommon places where it might be difficult for you to decipher as to from where this cyst is arising and how one should tackle these ones. We know that the perimeniscal cysts, they are in communication with the joint cavity, and the cyst fluid consists of continuation with the joint, and hence you need to repair the meniscus as well as the capsular rent. So I'm going to present you three cases, and it's going to be a very short presentation and more so technique based. So he's a 28 years old male, knee pain for last 2 years. He had history of fall with a twisting injury, which was insignificant and did not see a doctor then. The pain continued and had occasional episodes of instability too. He visited an arthroscopy surgeon in Pune, and he was advised a physio for a while and come back if he doesn't improve, and then the further call to be taken. 6 months later, since he happened to be close to my hometown, he visited me for pain, occasional catching, inability to squat, and all the special tests for instability, meniscus injury were absent in this patient. So these were his x-rays, which were absolutely inconspicuous. They did not show anything. This was the index MRI which was done in Pune, where one can see there is some hyperintense shadow at the tibial attachment of the ACL. These were the only pictures available with the patient on the file, and one can see there are certain cystic lesions posterior to the PCL, and this actually extended onto the posteromedial side as well. So we got the MRI repeated. The report in the index MRI showed low-grade partial thickness tear in anterior cruciate ligament, and it was and there was fluid collection posterior to the posterior horn of the medial meniscus. On the repeat MRI, which we did after 6 months, we found that probably the ACL had healed very well. Now ACL is looking absolutely jet black, and it's looking absolutely intact. One can see that there is a huge amount of collection which has increased as compared to the previous MRI done, and this cystic collection starting from the PCL, it came onto the posteromedial side of the tibia. So can we have the first ARS question, please? So what could be the cause of cyst formation? Ganglion cyst from cruciate, perimeniscal cyst, meniscocapsular injury, unhealed ramp lesion. So it's a perimeniscal cyst with a healed meniscus. That's what the maximum people want to stay with. But if you see this now, now this is the meniscus, and we thought, we were working on this ramp lesions in the recent past, and we were conceptualizing that if the ramp lesion is all about meniscocapsular lesions and meniscotibial lesions, then why are we not attaching meniscotibial and meniscocapsular ligaments to the bone as they belong to bone? And why are we repairing that to the superior surface of the meniscus? We went through certain anatomical studies as well to quantify this. So if you consider a ramp lesion, it is MCL, MTL, and MCL and MTL is attached to 36% of the height of the posterior horn of the medial meniscus. Although anatomists, they have differences of opinion in this, there was one paper which talked about superior attachment of these capsular, meniscocapsular structures, and we probably simulated this to something called as Bankhart's lesion in the shoulder. If it is a bony peel-off of a meniscocapsular ligament, then why are we fixing it to the meniscus? And the second anatomical structure, which was more important, was semimembranosus, which has got a direct pull onto these structures. So if you see this MRI now, that is the articular capsule, this is the meniscus, this is the superior surface of the meniscus, this is probably the meniscocapsular ligament, and this is the meniscotibial ligament. So we thought this is a neglected ramp injury along with the initial episode of the ACL, which was labeled as a partial tear of the ACL, and the translational injury has given rise to residual cyst in the posteromedial aspect. So we went through the anatomical studies where you find that there was only one study which talked about superior edge of the posterior horn of the medial meniscus by Cavignac. De Filippo, Smigleski, De Franchi, all these people, they said that it is inferior attachment of the meniscocapsular structures which is attached to the inferior surface of the meniscus. Now here we also, in search of the literature, we also found that there is no attachment to the superior surface of this area of the meniscus. So we thought we should do, and to add, De Filippo also quoted that there is nothing like meniscotibial ligament. It's just a condensation of the tissue, whereas the rest of the studies it said that it had a definite type 2 collagen fibers simulating the ligament. We thought we should also do a representative study, so we did an anatomical study, and this was just a single cadaver dissection which we performed, where we found that there was no superior surface. The MCL, MTL was onto the inferior surface, and the histopathological study done at 3 sections showed ligamentous structures or ligament-like structure having there. So probably we thought that it is the MTL and MCL which is more important, and it needs a repair to the bone rather than just repairing this stuff to the posterior horn of the medial meniscus. That tendon plays an important role in causation of the injury. The attachment sites were also studied by different researchers, De Filippo, Cavaignac, Kaplan, Laprade. Laprade showed about 8 attachments of the direct arm of the semimembranosus, whereas the most consistent studies were inferior surface of the meniscus, and it is attached to the bony surface about 6 to 10 millimeters below the joint line. So we thought this is a good opportunity to see and dissect this lesion from posteriorly to understand the anatomy, and this is what we found. This was anterior scopy. There was a small ganglion cyst at the tibial insertion of the ACL, which we obviously shaved off, but the ACL looked absolutely intact there. Then by doing a Gilchrist maneuver, we went to do the posteromedial compartment, and the yellow dots you see is the ganglionic tissue. There is a very thin, flimsy layer of capsule which is present there, which we envisage that even if you repair something posteriorly, these lesions will synovialize. So that's the capsule. That is how the cyst was exposed, and on puncturing we found that the fluid came out of this cyst. This was a multiloculated cyst, and we thought that we should dissect this posterior side layer by layer arthroscopically, because it has already been done histologically to see how it looks like. So that is how the cyst looked like. The cyst wall was taken off, and now you can see the posterior horn is absolutely free of attachment. That's the inferior surface of the meniscus. From there the capsule starts, and right from Strobel everybody had said that the ramp lesion occurs at the ramp and doesn't occur at the meniscus. 2019 ESCA consensus also says that a ramp lesion does not consist of a true meniscal tissue. So that is how the cyst was decompressed, and we took accessory medial portal to take out all this meniscal tissue, took a biopsy, sent it for biopsy to find that it was a cystic wall present there, and then shaved off the lesion from posterior side. So if you see from the posteromedial portal now, one can see the attachment of the MTL there. That's the articular capsule. That's the MTL attachment onto the tibia and the meniscus, and that probably is the lesion where you find these lesions. So taking this into consideration, we thought, why not attach this posteromedial capsule and treat it as a Bankart's, and we developed a technique. So this is our technique for repair of ramp lesion, which has been accepted by arthroscopy techniques and soon will be published. So that's a ramp lesion. The superior surface of the meniscus looks intact. We come in from the posteromedial port, and then we use all those instruments used in shoulder surgery to fix this Bankart's of the knee to the posterior aspect of the tibia. So that is the injury to the MTL. You can see MTL is avulsed from the posterior surface of the tibia. All principles dealing with the meniscal healing are taken care of. Just to cut the story short, that's how the suture fix has been passed onto the posteromedial side of the tibia, and with an antegrade suture passing device passed over a 6.5 millimeter transparent cannula, you take a nice bite because you get around 12 millimeters with a first pass mini, which will take a proper bite through the MCL and MTL, and then you tie this onto the posterior aspect of the tibia. So you can have either a one suture or two sutures going there, and these are what we call as meniscotibial and meniscocapsular separations. So those are two sutures which are being taken, and in interest of time, I'll just cut this short to show you how the ramp is reformed now. This is attached to the posterior tibia, and this will get synovialized to give rise to a proper ramp repair. We have done as yet about 20 cases. We are in process of presenting them as a review case as well. So if you consider now with the meniscus tear, you have a similar kind of injury where you have a posterior ramp. So I'll skip the technique of the posterior ramp. That is the ramp repaired by the technique shown by us. And this patient also had a double meniscal tear with a flap tear. Now, since we have a posterior capsule intact on the posterior side, these tears can be dealt with by a mere anterior approach using all inside devices. And this was then fixed to the capsule. Since the capsule is stable, there is no harm and there is no technical difficulty in engaging the posterior capsule by using all inside devices. So that is how all inside devices were used to fix the meniscus tear. And to show you the final result, after taking sutures in multiple configurations and accepting a philosophy of resect and repair, that is the final picture of a ramp repair from in front. That's the meniscus repair, which has been repaired to the capsule, and you have converted a type 3 lesion into a type 1 lesion, which will get synovialized and healed. So we also confirmed this by a patient where we received this patient. This is the initial ramp injury, which was treated 5 years ago with the same technique. This patient also had an ACL tear, and this patient came back to us in last month with a re-tear of the ACL. Now you can see here, that is the bucket handle tear of the medial meniscus. So there was a re-tear ACL, bucket of the medial meniscus, and if you see the posterior structures, that is our repaired ramp. This is our suture anchor which was placed here. You can see the meniscotibial ligament being formed there. That's the articular capsule. That's the meniscocapsular junction. And that's a bucket handle tear and a bone bruise there because of the bucket handle injury. So it was MRI proven, and we went inside for a revision ACL to see how the ramp is behaving. And to our surprise, we saw that it has been nicely synovialized, the ramp is intact, and the patient had a bucket handle tear. So that was a confirmation of the theory of synovialization of a ramp repair using this technique. Although this technique is still in evolution, we need to find out and have some further studies going as to find out what are the forces acting while the ramp lesion is caused. Is it translation or pull of a semimembranosus? But we definitely need to review that what are we really repairing? Are we repairing MCL, MTL, or are we repairing it to the meniscus? If MCL and MTL are the main anatomic structures in the ramp lesion, then they should be attached to the bone. And further biomechanical studies are required to validate our findings.